this is time to start our module 4, and whatever we have learned in last 3 modules, we are going to put it all together in this one exercise, which is about how to read a 12 lead ECG. Here in this module, we are going to learn how to interpret 12 lead ECG by using 7-step approach. And we will have exercises in the end. So this 7-step approach we learned in the step by step throughout this module, and these steps includes the rate, rhythm, axis, hypertrophy, interventricular blocks, infarction, and miscellaneous. Let's apply all these steps in a real-time ECG. It's a 16-year-old boy ran into a guardrail while riding a motorbike. In the emergency department, he's comatose and dyspneic. This is the ECG. Have a look on this ECG as a whole. Journal how the ECG looks like from the distance. Look at the AVR and look any gross abnormalities seen. Is there any rhythm strips? Are there 12 leads available? So look everything about this ECG on this ECG. Okay, so let's apply the first step. What's the rate here? We have learned various methods. So just to look at the rate, we have to look at the rhythm strip. And at the rhythm strip, it seems regular, and the rate is like 300, 150, around 130, 140 beats per minute. So this is definitely tachycardia. Now next step is the rate is 130 beats per minute approximately. So next step is what's the rhythm? Again, we have to look at the rhythm strip, which is the lead 2 on the bottom of this ECG. And if we see the rhythm is irregular, so definitely it's coming from the one source, and we have a nice shaped P wave throughout, followed by chorus complexes. So this is sinus rhythm, and the heart rate is more than 100. So this is your sinus tachycardia. What's the axis here? For the axis, we have to look at the lead 1 and AVF and see the direction of the chorus complexes. So lead 1 is mostly negative and lead AVF is mostly positive. So our axis is a right axis deviation in this ECG. Look at the hypertrophy. First we have to look at the atria, then the ventricles. As far as the atrial hypertrophy is concerned, look at the lead 2. And is there any tall P wave more than 2.5 mm? So answer is no. For ventricular hypertrophy, look at both the left and right ventricles. So first left ventricle, look at the S wave, the deepest S wave, V1 or V2. So in V2, it's deep, 1, 2, 3, 4 big boxes, and see the R wave in the V5 and V6 is very small. So there is no left ventricular hypertrophy. For right ventricular hypertrophy, look at the tall R wave in V1. It's not there, so there is no ventricular hypertrophy. Is there any bundle branch block? The next step. So for bundle branch block, you have to look at the wide chorus complexes in V1 and V2, or V5 and V6. So there are no wide chorus complexes, so there is no bundle branch block, neither left bundle branch block nor the right bundle branch block. Now it's the time to look at the ST segments. First look at, is there any ST segment elevation? So yes, in 1, AVL, V2, V3, V4, V5 and V6. In all these leads there is ST segment elevation, and lead 2, 3 and AVF there is slight depression. So this elevation in chest leads as well as in the lateral leads is your myocardial infarction, and lead 2 and 3 and AVF is the reciprocal changes. Any T wave abnormalities on this ECG? Any T wave inversions? Not really. Any abnormal Q waves? Yes, you can see in lead 2, V2, V3, V4, V5 and V6 and 1 and AVL. Yes, in the anterolateral leads you have the Q waves, and this is very significant Q waves. Anything else interesting? So obviously, if you see the QT interval is slightly prolonged, just borderline 0.482 corrected QT according to the heart rate, and this patient is a very young patient and got the chest trauma as well, blunt trauma. So my findings for this ECG includes, this ECG shows a sinus tachycardia at 130 beats per minute, right axis deviation, long QT interval, and evidence of ST elevation infarction in the anterolateral leads. Those include the V1 till V6, lead 1 and AVL, with the reciprocal changes, that's the ST segment depression in the inferior leads 2, 3 and AVF. So, but if you see the whole ECG and take the history, so this is probably a blunt chest trauma. The ECG is secondary to the myocardial contusion. This patient is, of course, is not a candidate for thrombolytic therapy, as this is trauma induced. So again, a checklist. We have to review the checklist once more before going through all the exercise in the coming slides. So checklist includes, have a general look at all the leads, especially the AVR. AVR is normally negative, but if AVR is positive, it means something wrong with the ECG. Look at the calibration and speed, and then follow the steps. The rate, that can be normal, bradycardia, tachycardia, then the rhythm. Look the rhythm is regular or irregular, then the P wave relationship with the QRS complexes, that will be 1:1, QRS duration and PR interval. Then the third step is the axis determination. Axis may be normal, left axis deviation, right axis deviation, or there may be extreme right axis deviation. And the fourth step is about the hypertrophy. Look at the atrial hypertrophy first, both the left and right atria, and then look at the ventricles, both the left ventricular hypertrophy and right ventricular hypertrophy. In the fifth step, you are going to see the interventricular blocks, both the right and left bundle branch blocks, and the fascicular blocks or hemi blocks. And the step 6 is about the infarction. Look for the ST segment elevation first, then ST segment depression and T wave inversion, then Q waves, and finally R wave progression. And the final 7th step is the miscellaneous findings on the ECG. Look for the QT interval, any U wave or J wave, PR segment, look at this one, and keep in mind the lead misplacement and artifacts. And finally, it's very important to correlate your ECG findings with the history and physical examination. If you follow all these steps, then there are maximum chances you will reach some conclusion, some diagnosis at the end. But if you go haphazard, then chances that you may miss some important findings. So in this exercise which we are going through, we'll just try to apply all these steps rather than making a straightforward diagnosis. So let's begin with the case 1. It's a 58-year-old man with the chest pain. Have a look at the ECG as a whole. And first step, rate. So look at the rhythm strip for rate. So if you look here, it seems regular, so you can apply any method. So rate looks 300, 150, 100, 75. So rate looks normal. And then the next step is the rhythm. Look at the P wave followed by the chorus complex and T throughout. Shape of the P waves are the same. So it looks like the rhythm is coming from the sinus node. So sinus rhythm. Axis. Look at the lead 1 and AVF. So axis looks fine, normal axis. Any hypertrophy? First atrial hypertrophy in lead 2. P wave in lead 2. There seems to be no atrial hypertrophy. Look at the ventricular hypertrophy. If the chorus complexes are wide, it's better not to comment on the hypertrophy, ventricular hypertrophy. So like here in this example, these are the wide chorus complexes. Look, any bundle branch block? Yes. If you look at the lead V1, there is a tall, wide QS intervals are big, wide R wave and deep S wave in V6. So there is right bundle branch block. Then the ST segment elevation. Yes, there is ST segment elevation in lead 2, 3, V2, V3, V4, even V5 as well, and doubtful in 1 and AVL. Anything else interesting on this ECG? All right. The patient is symptomatic, the chest pain. So this is significant. So our findings can be summarized as the rate is about 80 beats per minute approximately, and the rhythm is normal sinus rhythm, normal axis, no hypertrophy, right bundle branch block is there, and there is acute anteroseptal myocardial infarction. And as far as the miscellaneous is concerned, nothing specific except the patient is symptomatic. So this is your acute anteroseptal myocardial infarction. Case number 2, an 80 years old woman with history of mitral valve replacement for rheumatic heart disease. Okay, so just have a look at this ECG and try to apply the 7 steps. So rate. So rate and rhythm, you will look at the bottom of the ECG. So this looks like irregular ECG. So the rate, the method to determine the rate should be 6-second method. So let's apply 6-second method here. So as there are no marking on the ECG, so first 6 seconds is equal to 30 big boxes. So let's count the 30 big boxes starting from here. 1, 2, 3, 4, 5, 6. Till here, these are the 30 big boxes. And see how many R intervals here. 1, 2, 3, 4, 5, 6. 6 times 10 is the 60 is your heart rate. So this ECG, the heart rate is 60. The rhythm, it's irregular rhythms. You cannot see P wave, and these are narrow chorus complexes. So there is no P wave, so no PR interval, and this is totally irregular, no P wave. So this seems atrial fibrillation. Axis, so V1 and V2 both are positive, so seems to be normal axis. Hypertrophy, look at the lead 2 for atrial hypertrophy, seems to be P wave seems to be normal in size. For ventricular hypertrophy, look at the lead. For left ventricular hypertrophy, look at the deepest S wave in V1 or V2. So V2 is the deepest, and V5 or V6, look the tallest R wave. So if you combine, it's less than 7 big boxes or less than 735 and less than 35 mm. So there is no left ventricular hypertrophy. There is no right ventricular hypertrophy as well. But as far as the ST segment is concerned, look at lead 1 is okay. AVL is inverted, but look at the lead 2 and lead 3. There are downsloping P wave inversion, and it's more nicely seen in the V4, V5, and V6. So this looks like downsloping of the ST segment. So patient is 80-year rheumatic heart disease. Maybe this is the digitalis effect. Other possibility, this may be ischemia. Okay. So as far as the bundle branch block is concerned, there is no wide Kurtz complexes are seen. And let's summarize this ECG. The rate in this ECG is approximately 60 beats per minute, and the rhythm is atrial fibrillation, normal axis, no hypertrophy, no bundle branch block. There is STT changes, as I mentioned. Maybe this is a digitalis, and no other findings. Okay, so next is the case 3. A 76-year-old asthmatic comes to the emergency department complaining of increased shortness of breath. So the rate and rhythm will look at the bottom. Looks like regular ECG. So we can apply any method for the rate. So rate is approximately 95, 90. Rhythm P wave followed by the Kurtz complexes everywhere. So looks like the rhythm is coming from the sinus. It's a sinus rhythm. Axis, look at the 1 and AVF. So negative Kurtz complexes in lead 1 and positive in AVF. So right axis deviation. Hypertrophy atria, looks like P wave is tall in lead 2. So maybe right atrial hypertrophy. Then any ventricular hypertrophy. So looks like there is a tall R wave in lead V1 and V2 and deep S wave. So differential diagnosis is here is the right ventricular hypertrophy versus right bundle branch block. If you look carefully, this is less than 3 big boxes. So not very wide to be labeled as right bundle branch block, but right ventricular hypertrophy, and there is ST depression in lead V2, V3. So that may be a strain pattern. So right ventricular hypertrophy with strain pattern, and the patient about the QT interval, U wave, J wave, we can't find anything. So the patient is asthmatic and he's with shortness of breath. So it means this is a ECG of diseases of the right side of the heart, disease of the lungs. So the findings in the ECG includes the rate 95 beats per minute, and the rhythm is sinus. So this is normal sinus rhythm. There is right axis deviation. There is right atrial hypertrophy. There is right ventricular hypertrophy, and with strain pattern. No bundle branch block, no infarction, and as far as the miscellaneous is concerned, nothing significant. Okay, so case number 4. An 18-year-old boy with atypical chest pain. Okay, so look at the history. The young boy with atypical chest pain. So let's apply our steps of ECG interpretation. So the rate and rhythm at the bottom. So this looks like a little irregular ECGs. If you see the RR distance here is different, and in this place is different RR. So we'll follow the 6-second method of rate determination. So 6 seconds means 30 big boxes till here. 30 big boxes, and see how many are 1, 2, 3, 4, 5, 6, 7 or 8. 8 times 10 is the 80 is heart rate, 70 or 80 approximate heart rate, because the heart rate you will calculate will be approximate. The exact heart rate will be calculated by the ECG machine. The rhythm, it's very important rhythm here. If you look here, there is P wave followed by the Kurtz complex everywhere with 1:1 ratio. So this looks like the rhythm is coming from the sinus node, but it's irregular. So this rhythm is sinus arrhythmia because of young age, atypical chest pain, breathing pattern. This can cause the sinus arrhythmia. Axis, look at the 1 and AVF, both are positive, so normal axis. Hypertrophy, first atria, no right or left ventricular hypertrophy. If you look at the P wave and lead 2, as far as the ventricular hypertrophy is concerned, first look at the left ventricular hypertrophy and let's apply the voltage criteria. Look at the V1 or V2 S wave, which one is the deepest? In V1 looks deepest, and take the R wave, the tallest R wave in V5 and V6. V5 is the tallest. So combine the voltage in two leads, like 1, 2, 3. 3 big boxes here, 4, 5, 6, 7. So it's like 8 big boxes, which is equal to 40 small boxes or 40 millimeter. So any Current voltage more than 35 mm in lead V1 or V2 plus V5 or V6 is equal to left ventricular hypertrophy. So this patient has left ventricular hypertrophy. There is no right ventricular hypertrophy. As far as the bundle branch block is concerned, the Kurtz complexes are narrow, so no evidence of bundle branch blocks. ST segment elevation, it seems the ST segments are suspicious here in V2, V3, V4, V5 and V6 as well, and 1 as well. So look, is there any ST segment depression associated? Reciprocal changes? No. So this is doubtful ST elevation, and there is a notch at the end of the Kurtz complex before the ST segment, this notch. And the D wave, like if you see in the V2, are quite tall. So this is the ECG of benign early repolarization. So findings includes rate 70 beats per minute approximately. It's a sinus arrhythmia, axis normal, left ventricular hypertrophy is there, no bundle branch block. There is ST segment elevation in V2 to V6 with the notching, and the diagnosis probably here is benign early repolarization. And the shape of ST segment elevation is also concave shape, which is doubtful. Anyhow, let's proceed to the next case number 5. Here, a 67-year-old man complaining of dyspnea. So from the distance, it looks very abnormal ECG and very fast, wide complex arrhythmia, it looks like. Anyhow, for the rate and rhythm, let's focus on the lead 2 on the bottom, and it looks like a regular complexes, and the rate is close to 200, 220 something, very fast, and these are the wide complex tachycardia. So no P waves are seen. So this is wide complex tachycardia, probably ventricular tachycardia. So if it's a wide complex tachycardia, let's apply the Brugada's algorithm here. And the first step is look at the RS, whether it's lost or not in any of the chest leads. So the RS is lost in V1, V2, V3, V4 and V5. So probably this is ventricular tachycardia. And look at the Brugada sign here. Brugada sign is also positive. The distance between R wave and the depth of the S wave, if it's more than 2.5 small boxes, it's in favor of ventricular tachycardia. Yes, it's there. And axis. Next step is the axis. Here, very bizarre axis. Like, look at the V1 and AVF. Looks like bizarre right axis deviation. Very funny axis here. Hypertrophy. You don't comment hypertrophy if you get a wide complexes on ECG. In Fox, a bundle branch block, even when it's a fast tachycardia like this one, it's very difficult to look at the bundle branches. But if you look at here at V1 and V6, it looks like the right bundle branch block pattern here. ST segment, when the Calculus complexes are very wide, the ST segment may obviously seen as elevated, which may be a normal findings with such complexes. So anything else interesting on this ECG? So this patient is symptomatic. This patient has dyspnea. So this is symptomatic wide complex tachycardia. The rate here is 170 beats per minute approximately. Rhythm is wide complex tachycardia, and most probably the ventricular tachycardia. There is bizarre right axis deviation. Hypertrophy cannot be commented in presence of such wide coarse complexes. There is the right bundle branch block pattern, and it's difficult to comment on the ST segment elevations and T wave inversions. And as far as the miscellaneous is concerned, this is a symptomatic tachycardia, symptomatic ventricular tachycardia. Okay, so case number 6. This is the ECG of a 21-year-old female with history of seizure disorder. She is on no medication and her electrolytes are normal. Look at the ECG as a whole from the distance. All right. So rate and rhythm will check on the rhythm strip. So the rate looks like because regular rhythm. So see which R wave falls on the thick line. This one. So 300, 150, 100, 75, 60. So like 65, 60 heart rate. Then the rhythm. There is a P wave followed by the chorus complex throughout this rhythm strip. And same shape of P waves. So it means this is a sinus rhythm coming from the sinus node. Axis, look at the 1 and AVF, both are positive upgoing. So normal axis. Hypertrophy atria, P wave seems to be normal in size, not big. So no atrial hypertrophy. Ventricular hypertrophy, look at the depth of the S wave, 1, 2, 3, 4. And the height of the R wave, it's not more than 35. So no left ventricular hypertrophy. Look at for the right ventricular hypertrophy, no tall R wave in V1. Bundle branch blocks, no bundle branch blocks as there are no wide coarse complexes in V1 or V2. ST segment, this looks, but J point is not raised, so there is no ST segment elevation here. ST segment depressions, maybe in one lead AVL is isolated. It should be more in 2 or more anatomically contiguous leads. No. T wave inversions, this is only here in AVL, maybe not significant. What else in the ECG? Is there any U waves? Probably this may be a U wave. Any J wave? No. What about the QT interval? Oh yes, If you look the QT interval from the beginning of the Q till the end of the T wave is more than 2 big boxes or more than half of the RR interval. So there is definitely long QT interval. And anything else interesting? Yeah, history is interesting. This patient has seizure disorders and her electrolytes are normal and she's not taking any medication. So that may be some congenital disorder which is causing the prolonged QT interval and seizures. So ECG findings includes the rate 60 beats per minute approximately. So it's normal sinus rhythm, normal axis, no hypertrophy, no bundle branch block, no elevation, but QT interval is prolonged 0.6 seconds, and this is one of the congenital long syndrome that's responsible for seizure disorder. Case number 7. This is the ECG of a 72-year-old man with disease spells. From the distance, this ECG looks like grossly abnormal and it looks slow. Anyhow, let's apply our rate and rhythm on the rhythm strip. So the ventricular rate looks very slow and the rhythm is irregular. So if we see the RR big boxes between two R waves, 1, 2, 3, 4, 5, 6, 7, 8, 300 times 8. So heart rate is approximately 30-40 beats per minute. So very slow. It's a bradycardia. Okay. So the rhythm. Look at the P waves. Yes, we have P wave with Kuros complex, wide Kuros complex, and T. But this P wave has no Kuros complex, and this P wave again it has. This one no. This one yes, Kuros complexes. This one no. It looks like one P wave is followed by the Kuros complexes, the other one is not. So this is a second degree type 2 AV block or Mobius type 2 AV block with 2:1 conduction. Okay, next is the axis. Look at the 1 and AVF. 1 is positive, AVF is negative. So this is your left axis deviation. If you get a left axis deviation, immediately look at the lead 2. If it's negative, then this left axis deviation is actually left anterior hemi block or left anterior fascicular block. Hypertrophy, don't comment hypertrophy in presence of wide Kuros complexes like in this ECG. So we'll omit this step. And next is the bundle branch block. So there is obviously wide Kuros complexes in lead V1 negative and positive Kuros complexes with a notch in V6, V5 and V6. So this is your left bundle branch block. And ST segment, the 6th step ST segment, there is no ST segment elevation or no ST segment depression, no T wave inversion. So the issue is mainly the rhythm. Okay, anything else interesting in this ECG? So this patient is old with disease spells because this patient has multiple blocks. So this ECG shows the rate of 40 beats per minute and 2:1 AV block infranodal. There is left axis deviation or left anterior hemi block. Hypertrophy, this step we can omit. There is left bundle branch block, no infarction, and the patient is symptomatic. So this is symptomatic bradycardia. Okay, so the case number 8. This is 18-year-old preoperative ECG for knee surgery. Look at the ECG as a whole. From the distance, it looks like okay, but if you just focus the lead 1, this is negative Kuros complexes. They should not be. and there is inverted P wave also. So something wrong in this ECG. Anyhow, let's see first the rate and rhythm in the rhythm strip. So the rate seems to be okay, but you know, this is irregular. So we'll apply the 6-second method. 1, 2, 3. So like 60 or 70 heart rate. Rhythm is irregular, but if you see, there are P wave followed by the Kurtz complexes and T. So it looks it's coming from the sinus node, but it's irregular. So it's a sinus arrhythmia. Axis, if only we'll see the lead 1 and AVF, it looks a right axis deviation here. Hypertrophy, atria, P wave is not tall. So no atrial hypertrophy. Ventricular hypertrophy, first look at the left ventricle. No left ventricular hypertrophy, no right ventricular hypertrophy because there is no tall R wave in V1. ST segment elevation, really no. Maybe some doubtful ST segment elevation, maybe these notches benign early repolarization changes, or may not be, not very obvious. No ST segment depressions. Anything else interesting, miscellaneous? U wave, J wave. What about the lead misplacement? It looks like lead 1 and AVL, they looks abnormal. So some problem with probably the lead has been misplaced. Okay, so the rate in this ECG is 70 beats per minute, and this is sinus arrhythmia. Right axis deviation, no hypertrophy, no bundle branch block, no infarction, and this right axis deviation is not the true one. It's false because there is a limb lead reversal. A right arm electrode is misplaced with the left arm electrode. So once you identify these ECG changes, you will correct this one. And the most important finding in this ECG was the inverted P wave. Once you see an inverted P wave in lead, one of your differential diagnosis is lead reversal. Other is the junctional rhythm, and one more is the dextrocardia. So here probably there was no junctional rhythm, there was no evidence of dextrocardia. So most probably this was the limb lead reversal. Okay, case number 9. This is the ECG of an 85-year-old male without symptoms on no significant cardiac medication. So look at this ECG. So from far it looks like this is a slow ECG. So it looks like some bradycardia. And let's apply our 7-step approach. The rate here is very slow, less than 40 even, and it's regular. There are P wave followed by the Kurtz complex and T, but this P wave no. One is followed by the Kurtz complex and T, the other one is not. This looks like second degree type 2 AV block, 2 into 1, or Mobius type 2 AV block. Axis, lead 1 is positive mostly and AVF is negative, so this is your left axis deviation. Hypertrophy, atria, P wave not very tall, so no atrial hypertrophy. Look at the ventricular hypertrophy, especially look at the left ventricle. So deepest S wave in V2, 1, 2, 3, 4, 5, 6, 7, 8. So 8 times 5, 40 mm. So it looks like left ventricular hypertrophy. There is bundle branch block, no. There is no wide Kurtz complexes, so no bundle branch block. ST segment elevation or depression. There is no significant ST segment elevations. no depression. So this patient is having asymptomatic bradycardia, second degree type 2 AV block, and this ECG shows the rate of 30 beats per minute, and the rhythm is 2 into 1 AV block or second degree type 2 block. There is left axis deviation, there is left ventricular hypertrophy, no bundle branch block, no infarction, and the patient is asymptomatic. So this is asymptomatic bradycardia. Okay, look at this ECG. This is the case number 10, a 49-year-old woman having palpitations. Okay, so look at this ECG. In AVR, there probably slight ST segment elevation, but let's apply the step-by-step approach. The rate here is fast, approximately 140, 150 beats per minute. So it's tachycardia. The rhythm is fast but regular, except this one beat. But most of the time it's regular. And the last beat is there is a wide chorus complex. So there is no P wave. So it's not coming from the sinus, and the chorus complexes are narrow. So this is regular narrow complex tachycardia, looks like supraventricular tachycardia, but in the end of the ECG there is PVC also. This SVT with one PVC. Axis seems to be okay, 1 and AVF. Hypertrophy, no P wave, so you can't determine. Atrial hypertrophy, no ventricular hypertrophy, no ST segment elevation or depression except in one AVR, that's doubtful. So this ECG shows the rate of approximately 150 beats per minute. It's a supraventricular tachycardia with PVCs, normal axis, no hypertrophy, no bundle branch block, no infarction, and the patient is having only palpitations. So this looks like a stable supraventricular tachycardia. Stable means hemodynamically stable, and the patient has no complaint other than the palpitations. Case number 11. This is the ECG of an elderly man presented to emergency department with dizziness and new renal failure. So from distance, this ECG looks like that there are very wide chorus complexes. And let's apply our stepwise approach. The rate is quite slow, but it's a regular rhythm. So you can see number of RR, a number of big boxes between two RR waves. 1, 2, 3. So quite slow heart rate, 40, 50 something. So rhythm, if you see here, this is a P wave with a long PR interval, then chorus complex, P wave with the long chorus complexes, and P with the long chorus complexes throughout. This looks like that the ECG is stretched. So PR interval is prolonged. So this is first degree AV block. Axis, so 1 and AVF looks like left axis deviation. Hypertrophy in presence of wide chorus complexes, the hypertrophy should not be commented. Any bundle branch block, so there is pattern of left bundle branch block, but it's not left bundle branch block typical. It's a pattern. ST changes. This looks like ST segment elevation, but in presence of wide bundle branches, that may be a normal finding. So as a whole, and ST segment and T wave, you look here, these T waves are tall, and these are very pointed T waves, tent shaped. So if you look at the miscellaneous history, this patient has a new onset renal failure, and this tented T wave and wide chorus complexes. This probably is due to the hyperkalemia ECG. And because the renal failure potassium is retained, so ECG findings includes the rate 42 beats per minute, approximately first degree AV block. There is left axis deviation, question mark, because it's not it's some bizarre axis deviation. Hypertrophy cannot be commented. There is left bundle branch block pattern, but the chorus complexes are really very wide. There are peaked T wave, and this patient has potassium level of 7.6 milliequivalent per liter secondary to the renal failure. So this is the ECG of hyperkalemia. So history is very important. This is a symptomatic patient with renal failure. Okay, this ECG case number 12 is of a 60-year-old female who comes to the hospital with history of anti-phospholipid antibody syndrome, and she has a chest pain. Okay, look at the ECG as a whole. So from distance it looks like some gross abnormalities, but we'll follow stepwise approach. So the rate and rhythm, look at the bottom. Look at the bottom of this ECG. So this looks like irregular ECG. So we'll apply the 6-second method. So like 60 beats per minute, 50 or 60 beats per minute. But the important rhythm, look at this rhythm. The P wave followed by the chorus complex with the normal PR interval. P wave with chorus complex is prolonged PR interval. P wave with chorus complex is more prolonged interval. More prolonged PR interval, and then this P is not followed by the chorus complex. And then the cycle is going to repeat itself again. So this looks like second degree type 1 or Mobis type 1 AV block. Axis looks like the normal axis. Hypertrophy, atria, no atrial hypertrophy, no ventricular hypertrophy, but ST segment changes are obviously seen here. There is ST segment elevation in 2, 3 and AVF. So this looks like your inferior wall myocardial infarction with reciprocal changes in 1 and AVL. There is doubtful ST segment elevation also in lead V2 and V3, and there are Q waves as well in 3 and AVF V2 and V3 as well. So as far as miscellaneous is concerned, this patient is symptomatic and antiphospholipid antibody syndrome. So this is an ECG which shows the heart rate of 50 beats per minute approximate. Rhythm is second degree AV block type 1 or Mobis type 1 with Winkie-Bach phenomena. Normal axis, no hypertrophy, no bundle branch block, inferior wall, acute myocardial infarction, and this patient is symptomatic with the chest pain. Case number 13, this is the ECG of a 52 years old with the chest pain. Again, from the distance, this looks like grossly abnormal ECG, and the rate is also very slow. It looks like bradycardia, and patient is the chest pain, so this looks like symptomatic bradycardia. So the rhythm, there is P wave followed by the chorus complex and T, but this P wave has no chorus complex. The next P wave has chorus complexes. The next is without chorus complexes. So one P is followed by the chorus complexes, the one is not. So it looks like 2 into 1 AV block or second degree type 2 AV block or Mobis type 2 AV block. Then comes the axis. 1 is positive and AVF is negative, so left axis deviation. Hypertrophy, no atrial hypertrophy and no ventricular hypertrophy. Bundle branch block, this looks like RSR pattern. So maybe, but it's not very wide. So maybe this is a partial right bundle branch block, question mark. ST segment elevation, yes, in lead 2, 3 and AVF, there is ST segment elevation, and 1 and AVL and V3, V1, V2, V3, there is ST segment depression. So inferior wall with reciprocal changes. But if we look at lead 1 and 2 and take it as R, so there is possibility that this is ST segment depression, maybe ST segment elevation as far as the posterior MI is concerned. So anyhow, the ECG findings includes rate 40 beats per minute, and the rhythm is important here. 2 into 1 AB block. There is left axis deviation, no hypertrophy. There is right bundle branch block, incomplete. Possibly there is infralateral acute myocardial infarction. In fact, it's an inferior wall myocardial infarction with posterior extension. And the patient is, of course, in chest pain. Okay, this ECG, case number 14, is of 55-year-old female with heartburn and dizziness. So this is symptomatic patient. Look at the rhythm. It looks slow. So it looks bradycardia, and it's irregular, but occasionally in between there is white coats complex. So let's see the rate. So it looks like below 60 heart rate. So it's bradycardia. Rhythm, there is no P wave throughout ECG, but the rhythm is regular, and occasionally in between this is white coats complex, which is PVCs. So a regular rhythm, heart rate below 60. Okay, no P waves. Probably this is junctional escape rhythm with 1 PVC. Axis 1 and AVF looks normal. Hypertrophy, no P waves, so atria cannot be seen. No ventricular hypertrophy. Maybe borderline left ventricular hypertrophy. 1, 2, 3, 4, 5, 6, 7, 8. Yeah, there is left ventricular hypertrophy. No right ventricular hypertrophy. Some extra notches are seen. These may be U waves, and U wave is a feature of bradyarrhythmias, especially it's very obvious here. So this ECG shows the rate 55 beats per minute approximately. This is a junctional rhythm with 1 PVCs, normal axis, left ventricular hypertrophy, and there is ST segment. We forgot to talk about the ST segment. And there is, if you see, there is ST segment depressions in V5 and V6, and the differential diagnosis in this patient includes the ischemic heart disease, the ischemia, because this patient has heartburn and dizziness, which is angina equivalent, or maybe left ventricular hypertrophy with strain pattern. So as the patient is symptomatic, we have to do the cardiac workout, cardiac enzymes, to rule out the ischemia. And there are few U waves as well. Okay, this is the case number 15, a 32-year-old with history of recurrent palpitations. So look at this ECG. So from a general look, it looks a normal ECG, but let's apply our 7 steps approach. So the rate looks normal, and rhythm, there is a P wave followed by the Quercus complex throughout. But as we are scanning the rate, there is a little doubt here that PR interval probably is short. So that might be, although that might be some sort of pre-excitation mechanism here. Anyhow, let's go through the next steps. Axis, normal axis 1 and AVF, hypertrophy P waves are not tall, so no atrial hypertrophy, no ventricular hypertrophy, maybe borderline, but not a gross hypertrophy, no right atrial hypertrophy. ST segment elevation, no. Then why this patient is having recurrent palpitations? So if we look carefully, especially look at the lead 2, there is short PR interval and slight widening at the base, slight slurring. If you look at the lead 3, slight slurring of the R wave. It's a difficult ECG, but the ECG findings in this includes the rate is 75 beats per minute, short PR interval, slurring of the Kurtz complexes, and this is best seen in lead V5, but here in lead 2 and lead 3 also seen. There is no axis deviation, no hypertrophy, no bundle branch block, no ST changes. So this probably looks like WPW syndrome, and as the complexes are positive in V1 and V2, this is type A WPW syndrome. This ECG, case number 16, belongs to a patient who is 32-year-old and presents with palpitation, shortness of breath, dizziness and hypotension. So this is really symptomatic patient. So looks like very fast. So this looks like tachycardia, definitely heart rate 220, 230. The rhythm, these are the wide Kurtz complexes, but at places it's irregular. You see the RR distance. So this looks like irregular wide complex tachycardia. So we can't find any P wave. So differential diagnosis here, probably atrial, wide complex atrial fibrillation. So let's see the other steps, then we'll come to the final diagnosis. So this is irregular wide complex tachycardia. Axis, it seems the left axis deviation pattern. Hypertrophy should not be commented in presence of wide Kurtz complexes. Bundle branch block, yes, there is a right bundle branch block pattern. ST segment elevation should not, because these are very obvious tachycardia. So ST segments and wide complexes, ST segment becomes a little bit wide and elevated at places, so should not be commented. Anything else interesting? So this patient, if you see the main finding here are wide complex tachycardia. So this may be a phi and beat, and these two are captured beats. So that might be a ventricular tachycardia. Other possibilities, atrial fibrillation with a right bundle branch block. Third possibility is atrial fibrillation with WPW syndrome. You can see there may be a P wave and slurring of the R wave, delta wave and wide Kurtz complexes. So here you may give differential diagnosis like atrial fibrillation with the right bundle branch block, atrial fibrillation with WPW syndrome. This may be ventricular tachycardia as the patient is symptomatic. So take it as symptomatic ventricular tachycardia and patient needs defibrillation. So the rate is 230 beats per minute. Rhythm is irregular wide complex tachycardia. There is left axis deviation. Hypertrophy should not be commented. Right bundle branch block pattern. No infarction and differential diagnosis as we discussed. Case number 17. This ECG belongs to a 57-year-old with palpitation. Look at this ECG, and let's follow our stepwise approach. The rate is 300, 150. So approximate 150 heart rate. The rhythm seems to be irregular, and P wave, some notches are seen. So this may be confused with the P wave. But here, if you scan the other part of the ECG, you can't get such P waves. So doubtful. But this is regular narrow complex tachycardia. So one of your differential diagnoses is sinus tachycardia if you think this is P wave, or SVT if you don't think this is P wave. Or the third possibility is look at the lead V1. There are notches, 2 notches here. So that may be a flutter wave. So whenever you see a heart rate of 150 in sudden onset tachycardia patient, so one of differential diagnosis with atrial flutter with 2:1 conduction. So like in this example, 2 flutter wave. So 150 heart rate, axis looks normal, 1 and AVF, no hypertrophy, atrial hypertrophy. Ventricular hypertrophy seems to be deep, S wave 1, 2, 3, 4, 5, 6, 7. Looks like left ventricular hypertrophy. ST segment elevation, doubtful. No ST segment elevation. And ST segment depression may be seen in V5 and V6. That may be left ventricular hypertrophy with strain. But the issue is here the palpitation and this narrow complex tachycardia with the differential diagnosis of atrial flutter with the 2:1 conduction or SVT. Sinus tachycardia is less possibility at 57 years of age. So this ECG rate is 150 beats per minute approximately. Rhythm is atrial flutter with the 2:1 conduction. Normal axis left ventricular hypertrophy, no bundle branch block, no infarction, and miscellaneous. The patient is having only palpitations. So this is stable atrial flutter with 2:1 conduction. If you can't conclude the diagnosis, you may treat as SVT because atrial flutter is treated like supraventricular tachycardia. And in fact, this is one of the supraventricular tachycardia. Okay, this is a case number 18, and a patient is 52 years old with palpitation. So let's apply our 7-step approach on this ECG. The rate looks fast. We'll come to the rhythm strip. So approximately 150 rate. The rhythm, if you look, there are few notches here, 1 and 2 notches, but it's a wide complex. So it's a wide complex tachycardia. So this doesn't look like P waves, but these are notches. So this may be the 2 flutter waves. Look at lead 2, even in AVF. So this may be atrial flutter. If you can't appreciate this P wave, then there are no P waves, then this is a wide complex tachycardia. Okay. So let's hold this for some time as a wide complex tachycardia. Okay, with rate of 150 beats per minute. Axis looks like left axis deviation. Hypertrophy in presence of wide coarse complexes throughout this ECG. No need to comment on the hypertrophy. Bundle branch block, if you look at the V1 and V6, looks like left bundle branch block pattern, left bundle branch block. ST segment, in presence of left bundle branch block, you will get the normal ST segment elevations, which are obviously seen. That may be normal findings. ST segment elevations are there, definitely these are there, but it is a part of left bundle branch block. Anything else interesting? This patient has palpitation. Okay, so the main finding on this ECG is to diagnose the rhythm. So rhythm is here wide complex tachycardia. So the possibility is, one of the possibilities, atrial flutter with 2:1 conduction with left bundle branch block. This is very difficult to say that this is a ventricular tachycardia. It's not. The SVT with left bundle branch block is the other possibility, but these notches, two notches, are more in favor of atrial flutter with 2:1 conduction. And also, whenever you see in emergency department a patient with sudden palpitation without loss of fluid or blood and heart rate around 150 beats per minute, always keep a differential diagnosis of atrial flutter with 2:1 conduction in your mind. So here the rate is 150 beats per minute, wide complex tachycardia, that's atrial flutter with 2:1 conduction. There is left axis deviation, hypertrophy should not be commented. There is left bundle branch block, and ST segment elevation are normally seen in left bundle branch block. And if the patient has a chest pain or it's a new onset left bundle branch block, then you can apply the Sarbosa's criteria to rule out myocardial infarction in presence of left bundle branch block, and that includes the Sarbosa's criteria that the Kurus complexes and ST segment should be in the same direction, but here they are in the different direction. So there is no real myocardial infarction here. And also, if you get the invert ST segment depression in V1 and V2 and V3, this is again a criteria that the patient has myocardial infarction in presence of left bundle branch block, or if the ST segment elevation are very tall, more than 5 mm, then this carries the 2 point or the weakest evidence. Here there are ST segment elevation and quite far more than 5 mm, but alone this is not sufficient to diagnose my MI in presence of left bundle branch block. So there is probably no MI in the presence of left bundle branch block in this ECG. Okay, so next, case number 19 is a 49-year-old with palpitation. So let's focus the rhythm strip, rate and rhythm. So it looks like regular ECG, and the rate is approximately 150 beats per minute, 130, 140, 150. So it's tachycardia, definitely 140 beats per minute, and it's regular. The P wave in this rhythm strips are difficult to see, but some notches are seen. But if you look at the V1, there are obviously two notches. So this may be again atrial flutter with 2:1 conduction. Axis are 1 and AVF, its left axis deviation. Hypertrophy, no atrial in ventricular hypertrophy in presence of wide Kurus complexes, difficult to comment. Bundle branch block, there is RSR pattern, there is a wide R wave in V1. So there is a right bundle branch block. ST segment, no elevation, no depression. Only the AVR, probably little elevation is seen. That may be a part of right bundle branch block. So the ECG findings includes the rate approximately 140 beats per minute. This is again atrial flutter with 2:1 conduction. There is left axis deviation, no hypertrophy, and there is right bundle branch block. So no ST segment changes, so no infarction, and miscellaneous. This patient is having palpitation. So the final diagnosis: this patient has atrial flutter with 2:1 conduction with right bundle branch block. That's why the complexes are wide, especially if you look at the V1. This ECG is case number 20 of a 63-year-old with the dizziness and recurrent syncope. Let's apply our 7-step approach. The rate, it looks quite slow, this ECG. It looks a bradycardia. So it looks less than 60 heart rate. So it's definitely bradycardia. What's the rhythm here? This is regular. So it means source is from one place, but you can't identify any P wave, although the chorus complexes are there. So this looks like junctional escape rhythm. There is left axis deviation as 1 is positive and AVF is negative. Hypertrophy, difficult to comment on atria because no P wave are seen, but if you see the ventricles, 1, 2, 3, 4, 5, 6, 7, maybe left ventricular hypertrophy. Another evidence of left ventricular hypertrophy is look at the lead or wave in lead AVL. If it's more than 13 mm, like more than 2.5 big boxes, this is again in favor of left ventricular hypertrophy. So probably left ventricular hypertrophy is there. ST changes, there is, doubtful ST segment depression and T wave downsloping of the T inversions in one lead, not everywhere. So probably not very much significant, but as the patient has dizziness and recurrent syncope, so it's important here. And then this is additional waves. These may be U waves. These are the part of bradycardias. So to conclude, this ECG has a rate of 45 beats per minute. This is a junctional escape rhythm, left axis deviation, left ventricular hypertrophy. As I said, the tall R wave in AVL is also associated with left ventricular hypertrophy. There's no bundle branch block, no infarction. The U wave is seen in lead V2 and V3. So important message is that whenever you interpret ECG, just try to go through step by step. Then you are not going to miss many things. Case number 21. Here is the 56-year-old with strange feeling in the heart. So it looks like little funny ECG, but let's go to the rate and rhythm at the rhythm strip lead 2 at the bottom of ECG. So if you look at here, there are two different shapes of the chorus complexes, and they are regularly occurring. If you look the distance between this R wave, this narrow one to the other narrow one, it's the same. If you look at the distance between the wide chorus complexes, this one wide chorus complexes to other wide chorus complexes is the same. So here we can apply the 6-second method, for example. 2, 3, 4, 5, 6. So like 70 or 80 is the heart rate here. Rhythm is here 1 normal, 1 wide PVC, 1 normal, 1 PVC, 1 normal, 1 PVC. So this looks like ventricular bigeminy. Axis, look for with the normal chorus complexes. Normal axis, no hypertrophy as far as the atria is concerned, no ventricular hypertrophy. ST segment elevation not seen, ST segment depression. maybe in lead V5, V6, some T wave inversions are there. But the patient's, the main complaint is strange feeling in the heart, and the findings includes the rate 70 beat per minute, sinus rhythm with ventricular bigeminy, normal axis, no hypertrophy, no bundle branch block, no infarction, and this ECG is ventricular bigeminy. Case 22, the ECG of a 52-year-old with the chest pain and sweating. So looks like the wide complex is throughout the ECG, and have a look at the rhythm strip, the rate. The rate is here is 300. So it's less than 100. Okay. Like 70 beats per minute. This is a regular ECG, but no P wave. The course complexes are wide, and it's regular. So wide regular QRS complexes at a rate less than 100. So it looks like accelerated idioventricular rhythm. Axis, right axis deviation. Hypertrophy in wide course complexes, better not to comment on hypertrophy. Bundle branch block, this may be a right bundle branch block here. ST segment elevations, yes, it's seen in 1 AVL, V2, V3, V4, V5 and V6. Then anything else interesting? This patient has chest pain and sweating, so this is symptomatic patient. So the ECG findings in this patient includes the rate 80 beats per minute. The rhythm is accelerated idioventricular rhythm. There is extreme right axis deviation. No hypertrophy. There is right bundle branch block pattern, and there is ST segment elevation in the anterolateral leads. And so this patient has acute, and there are Q waves as well. If you can see the Q waves in the anterolateral leads. So this is recent myocardial infarction, anterolateral myocardial infarction. So patient has chest pain and sweating. Okay, this is ECG of case number 23, ECG of 49-year-old with palpitation and chest discomfort. Look at this ECG at the bottom for a rhythm strip. So this is irregular ECG. So we are going to see the heart rate by using 6-second method. So 6 second, we have to calculate the 30 big boxes. So it's here 1, 2, 3, 4, 5, 6, 7, 8, 70, 80 beat per minute is the ventricular rate. Rhythm, this is irregular, and but if you notice, there are P wave followed by the Kurtz complex, and this is again P wave with Kurtz complex, P wave with Kurtz complex. But if you see the P waves, two different shapes of the P wave. One is small, one is large. One is small, one is large. So it means there are two sources. One probably is the sinus, and other is ectopic. So, and in between there is PVC as well, or maybe from the third ectopic focus, because there is a P and Kurtz complex, but in opposite direction. So this looks like, you see, the mostly this may be atrial bigeminy. The rhythm is atrial bigeminy. Axis, a normal axis. Hypertrophy, atrial, no. Ventricular hypertrophy, 1, 2, 3, 4. Maybe borderline left ventricular hypertrophy, ST segment elevation in V1, V2, V3 seems to be ST segment elevated. So ECG findings includes the rate 100 beats per minute approximately. So it's a sinus rhythm with atrial bigeminy. As I mentioned, two different shapes of the P waves. Normal axis left ventricular hypertrophy is there, no bundle branch block, and there is ST segment elevation in V1 and V2 with poor R wave progression in V1 and V3. You can see the poor R wave progression. Alright, this case number 24, this is ECG of a 69-year-old with palpitation, dizziness and chest tightness. So this is a symptomatic patient, case number 24. So this looks very bizarre ECG, and from the distance it looks there are extra spikes in this ECG. Okay, let's go to the stepwise approach. The rate here in this first half of the ECG is slow, but in the second half it's fast, and the torus complexes are wide in the second half. In the first half also wide, but not as wide as in the second half. And the second half they are very fast. So it looks like this is the pacemaker here. This is a pacemaker rhythm, and here the pacemaker is not sensing, and it's taken over by the wide complex tachycardia, which is a different shape polymorphic ventricular tachycardia. So paced rhythm with failure to sense followed by the polymorphic ventricular tachycardia. This is the rhythm. So in case of pacing ECG, it's very difficult to comment on the axis and hypertrophy, because these axis and hypertrophy and ST segments and bundle branch blocks are difficult to comment in these cases of paced heart, because these are altered. So the main ECG finding in this case is the rate is the 150 beats per minute, and it's ventricular pacing with intermittent sensing failure causing the polymorphic ventricular tachycardia, and this is symptomatic patient, and it should be consulted with cardiologist as far as the pacing is concerned. Case number 25. This patient is a 56-year-old with history of congestive cardiac failure, presented to the emergency department with palpitation and shortness of breath and also dizzy. So looks like very wide course complexes. Let's follow step-by-step approach. So rate, as this ECG looks like irregular, so we'll follow the 6-second method. So you have to take the 30 big boxes which are equal to 6 seconds. /90 or 100 heart rate, even more than 100 heart rate. The rhythm at its irregular, so probably this is atrial fibrillation, but chorus complexes are wide. Axis looks normal. Hypertrophy in presence of wide chorus complexes should not be commented. There is left bundle branch block pattern, or maybe this is left bundle branch block. ST segment elevations are seen, but these are normal features in presence of left bundle branch block. So the ECG findings includes the heart rate of 120 beat per minute, and the rhythm is irregular wide complex tachycardia, probably atrial fibrillation with left bundle branch block. This is ECG of a 48-year-old comatose woman. So looks like this ECG very bizarre and very deep. These T waves throughout the ECG. But let's apply our 7 steps approach. The rate looks slow, but the rhythm is, if you see the P wave followed by the Icarus complexes throughout. So this is a sinus rhythm coming from the sinus node. Axis 1 and AVF. If you look at the 1, the positive and negative are the same, and AVF positive and negative part of the Icarus complex is the same. So its isoelectrical line are indeterminate axis. Hypertrophy is difficult to comment on. Atrial, no atrial hypertrophy. Ventricular hypertrophy, 1, 2, 3. Ventricular hypertrophy, left ventricular hypertrophy is there. ST segment elevations are not there, but depression T wave inversion, giant T wave inversions are seen throughout the ECG, except AVR and AVF. And this patient is comatose. Okay, so means this may be an ECG secondary to the central nervous disease and maybe raised intracranial pressure, something like subarachnoid hemorrhage. So the findings in this ECG includes the heart rate of 58 beats per minute, sinus bradycardia is the rhythm, no axis hypertrophy, nil, but probable possibility of left ventricular hypertrophy is there, no bundle branch block, and deep T wave and QT interval is also prolonged here because of wide and deep giant T wave and slow heart rate. So this is a CNS disease. Case number 27, a 39-year-old female with breast cancer. Potassium is 3.6. So normal level of potassium is 3.5 to 5 milliequivalent per liter. So it means potassium is normal. So let's look at this ECG. The rate in this ECG seems to be normal, and the rhythm, there are P wave followed by the chorus complexes. P wave with chorus complexes. So it's a sinus rhythm. Axis 1 and AVF seems to be normal. Hypertrophy P in lead to no atrial hypertrophy. Ventricular hypertrophy, probably there is ventricular hypertrophy. Left ventricular hypertrophy is there. ST segment looks like no ST segment. S wave ends and T wave starts. Very short or absent ST segment and short QT interval. So ECG findings includes the rate 90 beats per minute and rhythm is regular. So it's a normal sinus rhythm. Normal axis left ventricular hypertrophy is there. No bundle branch block and absent ST segment and short QT interval. And this is a feature of hypercalcemia. And this patient has breast cancer. So metastatic breast cancer causes the rise in the calcium. So the hypercalcemia ECG. Case number 28. This ECG is of 33-year-old woman 2 days post-operative. And it looks low voltage ECG. The rate, if you look at there is no rhythm strip, but we'll just find the rate here. It's fast, approximately 140, 150 beats per minute. And there are P wave followed by the chorus complexes. P waves are there. There are P waves. Okay, so this may be a sinus tachycardia or maybe atrial flutter with 2:1 conduction. But as the patient is post-operative, so probably sinus tachycardia. Axis 1 and AVF, there is a right axis deviation. 1 is negative, AVF is positive. Atrial hypertrophy, look at the lead 2. The P wave is quite big as far as the ECG sizes is concerned. So this is right atrial enlargement. Look at for the bundle branch blocks. Yes, there is possibility of right bundle branch block. Not the typical picture, but maybe there is a right bundle branch block. ST segment elevation may be seen in AVR and V1 and other. If you look at there is S wave in lead 1, S1, Q3, T3, Q wave in lead 3 and T inversion in lead 3. So this S1, Q3, T3 can be seen in 10 to 12% of the pulmonary embolism. So this findings includes the rate of 160 beats per minute regular sinus tachycardia, S1, Q3, T3 and R wave, R in V1. There is axis deviation, right axis deviation, right atrial enlargement, and there is ST segment elevation in V1 and AVR. So this ECG, which is a low voltage ECG, may be a feature of acute pulmonary embolism. And the most common finding in pulmonary embolism is sinus tachycardia. This ECG case number 29 belongs to a patient who is 82-year-old, seen for cardiac evaluation. If you look at the ECG, it looks a different ECG, and AVR is so positive. But look at the limb leads. This is also different shape. Look at the chest leads. They are also different. Okay, so R wave progression, if you look, it's very bizarre. Anyhow, we'll apply our 7 steps. The rate looks like slow ECG bradycardia, but there is a P wave followed by the Icarus complex. So looks like the rhythm is coming from the sinus node. Axis, there is right axis deviation. Hypertrophy is difficult to comment, but if we see the criteria for right ventricular hypertrophy, it looks like right ventricular hypertrophy. ST segments, there may be in only one lead, V1 it's inverted, but there is no ST segment elevation, and at places in different areas like T wave inversions are here. These are not in the anatomically contiguous areas, but 3 and AVF they are. So T wave inversions are there. But if you look the lead 1, there is a negative P wave, and we have discussed earlier the negative P wave can be seen in few conditions. One of them is the lead misplacement. So look here is not the lead misplacement. It's actually everything is misplaced. Other is the junctional rhythm. So here is not the junctional rhythm. And third possibility is the dextrocardia. So if you see the dextrocardia, it looks like that this is a V1, V2, V3, V4, V5 and V6. Like the ECG is recorded from the right side of the heart. So findings includes the rate is 60 and regular. Okay, inverted PU in lead 1 and positive Icarus complexes in AVR. So this is a normal sinus rhythm, but axis is extreme right axis deviation, no hypertrophy, no bundle branch block. There is ST changes in the chest leads, and it's a feature of dextrocardia. All these are feature of dextrocardia. So differential diagnosis of inverted P wave in lead 1 includes the dextrocardia, ectopic atrial rhythms and misplaced limb leads. And the case number 30, which is our last case of this exercise, a 22-year-old man with chest pain. Okay, so this looks like very big Icarus complexes here, and it's a young patient with the chest pain. So let's apply our stepwise approach. There is no rhythm strip, but we'll calculate the rate. The rate is here. Is a bit slow. Rhythm, there is B wave with cross complexes, so it's coming from the sinus. Axis 1 and AVF normal axis. Hypertrophy atrial maybe notched P wave, it's not sure, but the left ventricular hypertrophy is obviously there, and with deep T wave, maybe strain pattern. ST segment elevation may be seen whenever there is a high voltage ECGs like this one. ST segment elevation are expected, and these are concave shape, so this may not be dangerous. It may be a part of ventricular hypertrophy. And this ST segment depression are downsloping of the T wave. Then the sharp rise is a feature of strain pattern. And if you see the deep T wave are more over the leads which are towards the apex V4, V5 and V6. So these ECG findings includes the rate of 45 beats per minute regular sinus rhythm. So sinus bradycardia is there. Normal axis, left ventricular hypertrophy is obvious, left atrial hypertrophy is question mark. Bundle branch block is not seen, and there is ST segment changes, and these are secondary to the repolarization due to the left ventricular hypertrophy, and this patient has hypertrophic cardiomyopathy apical, as evidenced by the T4 deep T wave inversions in V4, V5 and V6. And thank you very much. We have used different sources with permission to prepare this course. You can further read these following articles and use the resources mentioned here. And thank you very much for your time. It's really appreciated. And if you have any comments or suggestions, don't hesitate to send me email on this address. Thank you very much, and see you again.